Lights out.
Welcome, everyone, once again to another episode of SleepTech Talk, the Sleep Podcast. Yes, hallelujah, we're here again, and we're looking forward to a great episode. Before we get started, just want to say thanks to each and every one of you out there listening to us, watching us on YouTube. We can't do this without your support, and we sincerely appreciate it. We've got a fantastic guest, and now we're officially across multiple time zones, coast to coast. Technology, we're able to do this. And hey, like I was just saying earlier, we put the tech in SleepTech Talk. So with that being said, let me hand it over to Emerson. Please, if you tell us a little bit more about what's going on today, Emerson.
Hey, thanks so much, Jerry. Good to see you and Robert tonight. It is tonight when we're doing this for us. So we really have the pleasure of having Julie Dewitte with us tonight from Los Angeles. Julie is with Kaiser Permanente, works in a great center there in the Los Angeles market. Julie and I met about 7 years ago, I think, in Branson, Missouri. We were working with Melinda doing a talk there, and it was such a great visit. We had such a great time. But Julie's history is extraordinary. Julie, I'm pretty sure, started doing sleep at the age of 5, and just had an incredible career. If I'm reading this right, you have your registry back in '93. So you and Robert definitely competing for your registry number there. But quite a history in Colorado, California, Las Vegas, kind of all over the place there. And then, if I counted right, you've got quite a few publications that you've been a part of, a few things that you've published. But I think the thing that has really drawn my admiration, the reason I wanted you on our show, is your work with pediatrics. You played a key role in the pediatric portion of the textbook. You've done a lot of work with the societies on developing some standards. You've served on a handful of committees. So there's a lot of great work you've done, and we're really honored to have someone of your caliber to be able to speak to us tonight about pediatric sleep. But before we dig into that, because I know that's your passion, how did you get here? Because I know for the three of us, we sort of fell backwards into sleep from respiratory or wherever we were. But for you, it looks like you had a respiratory start too. And how did you go from that to sleep medicine?
I kind of did fall in backwards. I actually, when I moved to California in the early 90s, I was working in a trauma center and pediatric intensive care hospital. And I just happened to be chit-chatting one night with one of the pulmonologists who asked me if I knew anything about sleep. And I was like, well, I need some sleep, but other than that, he said that he was looking for a respiratory therapist that would like to learn about sleep diagnostics in their sleep center. And I was like, well, I'm open to learn anything. So he started training me, and I absolutely fell in love with the field. And at that time, the only program was the program up at Stanford. So I went up there and went through the program and never looked back.
No, that's pretty much how the rest of us did it. I had the same experience. So why pediatrics? I mean, clearly you had a respiratory history with peds too, but what about pediatric sleep really drew you in and hooked you for life? Tell us a little bit about that.
Well, I love working with the little ones. They're vulnerable and they are difficult. They take a ton of patience, and people, they're kind of scared of kids. And, I learned not to be scared of kids working in the respiratory field. So I worked neonatal and pediatric intensive care, and I did transport. And, I just had an overwhelming feeling for them, just because they can't talk to us and tell us what's wrong. We have to figure it out. So it's, part of that holistic, kind of like a jigsaw puzzle. We got to take all those comorbidities. We got to look at these kids. We got to put it all together, make those pieces fit so that we can give them a better quality of life. And you have to really dig in and understand pediatric sleep because it's so much different than adults. These kids, you know, they need to sleep to develop. They're sleeping about 70% of their 24-hour period, where we as adults, we get about 25% or less. And, you know, and that's where they're going to grow, and that's where their brain is going to develop. And so we need to make that transition for them as much as we can to help them along with whatever types of comorbidities, be it prematurity, be it some type of genetic disorder, or whatever it is we need to do. And just looking in further into pediatric sleep, and you look at the history of pediatric sleep, it's pretty remarkable how new it is, you know, because they didn't even have a scoring manual till 1971, and that was only for infants less than 2 months of age. And what I found really remarkable was that the actual first treatment for obstructive sleep apnea, or I should say a complication of obstructive sleep apnea, was done by Dr. Christian Guilleminault. And he had a 10-year-old patient that was having uncontrolled hypertension. So he performed a tracheostomy, and that became the first successful treatment in a complication of obstructive sleep apnea, and it was on a child. So, you know, those kind of things. And then, you know, I got into this field in the 90s. There really wasn't much on pediatrics, and they didn't even have a publication of a sleep scoring manual until 2002. That's not very long ago. So, and the one thing I really laugh about is that, you know, they started doing a training program in sleep medicine, but on their very first exam, they only had 2% dedicated to childhood disorders. Not enough. And, you know, today we're still just untapping that surface of understanding pediatric sleep.
Julie, you make a really good point about that. It's two completely different things. How did you break that barrier? It came to, you know, I'm a physician myself, and I understand that it's two different sciences. Yet on the sleep side, we are still coming across this barrier, which is these are just small humans, not a separate sleep science altogether. So how did you work through that as a sleep technologist?
Well, by a lot of reading, a lot of research. Hasn't been a lot out there, but there's getting to be more and more and more, which is wonderful. And, you know, a lot of the work that we're doing, but you really have to delve in and understand what is the work of a newborn compared to the work of an adult. How are we going to recuperate and regenerate our bodies? And how is their brain going to develop? And, you know, and when you look at it closer and closer, and you read a lot of the works from a lot of these sleep physicians over the years, you really find how just their development of sleep, it is going to frame everything that's going to happen as they grow. And it's very different than it is for adults. So me being me, I just like to try to put two and two things together and see, like, okay, what is this working? What is this not working? How's the metabolism working? You know, it's a whole matter of just being able to learn and unlearn different things and make that distinction between pediatric and adult.
Julie, I've got two questions for you. I'll ask them, and if you forget the second one, I'll circle back and restate it. But the first question would be, because I know I've had my own personal experiences when I was a respironics rep, doing BiPAP AVAPs titrations on some pediatric patients, and just seeing the immediate difference that, you know, that type of therapy was able to make for a child, you know, who had respiratory insufficiency, or, you know, whatever the case may be. Do you have a story about a patient that you were able to significantly make a a change in their, in their day-to-day life just with the work that you did in the sleep center? And I'll save my second question for a second.
Sure. One of the things that really comes to mind is when I did start working with Dr. Dennis Hwang, because I've had a lot of people ask me, how do you know how to ventilate these children? And a lot of it is instinct, I think, and just understanding the cardiopulmonary physiology. But we had a patient that came in one night, and it used to be that Dr. Hwang would stay there with some of these really complicated kids. And so I was there one night with him, and we were working together, and he went to lay down. And this particular child, she was a teenager, early teenager, 13, I believe. And she had what's called ROHAD syndrome, and very difficult to ventilate. And in our sleep center, we monitor these kids and our adults actually with dual capnography. So we're using transcutaneous, and we're using end-tidal CO2. And then we're also using dual CO2, dual O2, so that we can really get a feel for if our numbers are clear, if they're correct. And I was just watching how she was breathing and watching her work of breathing, her respiratory rate. I was looking at the volumes that she was generating. And I looked up, and we actually at that point were using a Respironics device for volume assured pressure support. And she came in right at the cusp of where we could put her on therapy. So I put her on AVAPs and started titrating her. A couple hours later, Dr. Hwang came in, took a look at her study, and was just like, what did you do? How did you do this? And he was stunned that I would have tried that. But, like I told him, it's just a matter of really getting a feel for that patient. You want to look at not just one little tiny aspect of what's going on there in sleep, but you have to look at the entire picture of what's happening. And it just happened to work. And it worked very well for her for several years as she grew.
That's a great story. It's pretty similar to mine, except that being a sales rep, I was able to leave mostly once the patient was pretty stable and didn't have to stay all night. So that was pretty good.
You got the
yeah. The other question I had for you, because we're starting to see more, information and studies that are being done related to level 2 testing being done on pediatric patients in the home. Have you had that, been a part of any of that type of research? What's your thoughts on taking level 2 into a pediatric home?
Well, it's going to depend upon the age of the child and the development of the child. We've had some very successful studies with as young as 6, 7 years old, and we've had a lot of failed studies on 8 and 9 years old. So it's a matter of how involved is that parent going to be for that, and are they going to pull things off all night long, and then we're going to not have the data that we need. And that's one of the biggest things with kids. They don't like the cannula in their nose. That's a big deterrent. And they don't like the finger probe because it's a light. So we try different things. We, sometimes we'll put it on their toe, put it on a sock. So it's kind of out of sight, out of mind. We make sure we get everything bundled up. We give them a few extra little electrodes here and there, but it all comes down to the child, and you have to do a good evaluation on that kiddo before you ever determine that you want to go into the home and do a study for them. Because we're finding, especially on these younger ones, it's better to bring them into the lab and get a nice viable study the first night rather than trying to repeat 2 or 3 studies.
So, Julie, I'm really curious because in my previous lifetime, we worked a little bit with pediatrics. Any thoughts or any experience with pediatrics, sleep, and ADHD or ADD? Have you had any experience with that? And if you have, love to hear a little bit about that.
Yeah, we do get a lot of kids with ADHD, and a lot of times we find out that it's more of an obstructive sleep apnea issue than it is with the ADHD. And once that we control what's going on with their breathing, we find that their symptomatology gets better. So it is a matter of, again, looking at the child and being able to see, is this kid got tonsillar hypertrophy or big tonsils, big adenoids, right? Is a surgical procedure going to help? Is the child a Down syndrome child that has a big tongue, and that's going to add to more behavioral issues? Or is it an older kid that maybe has some developmental sleep going on, like delayed sleep phase? So we have to look at everything and then see what is going to be our best bet. And when we do studies on these kids, we follow them up very closely, and we want to get a history and a continuous history on how is that kiddo doing now? Is their ADHD improving? Is it, their airways has improved? Are we able to, if we had them on CPAP, can we wean them down now? And how is that now controlling their behaviors and helping them?
Julie, thank you so much. That's really interesting. I wanted to ask a few more questions because that's always intrigued me in the clinical practice side. So, but I sincerely appreciate it. And I know that opened up my eyes when I started working with that. But we are getting really close to time. Is there anything you'd like to add for the audience? Anything in particular? You got a couple of minutes to tell us anything right now.
Yeah, I think, always if you're in a pediatric sleep, keep an open mind and have a lot of patience, because that's what it's going to take. And there is always a way to get a study. If you have a child, because we do get a lot of autistic children also, and autistics, they don't be touched, they don't like things on them. So you have to think of ways that you can go through and get these electrodes on with as little trauma to the child as possible. Know when the child needs a break, know when to back off, let them go to sleep, go back in, put on some more electrodes, and keep going until you get it. I have so many different stories of different children that I've worked with, and there's always a way to get a study and get a good study and get these children the help that they need. And, I do have a big passion for pediatrics. I think everybody should work with pediatrics, but it really isn't for everybody. And, but they need help. And it's up to us as clinicians to help them and get them back to where they need to be so that they can grow and they can have a good quality of their life.
Julie, thank you so much. It's very obvious your passion, it comes through and through. And for those of you who are listening at home, I want to tell you that we really thank Julie, especially because she's recovering from an illness. And we thank you, Julie, so much for being able to come on, even though you're in the recovery stage. But we also want to thank every one of you for listening and tuning in. We can't thank you enough for all the likes, for all the subscriptions. Don't forget to share it with all your friends. There are thousands and thousands of techs out there. Make sure that each and every one of them are listening to this talk because it's for them. And until next time, just want to tell everybody, lights on.